Today we are going to see a case of laparoscopic right partial nephrectomy. This is a case of right mid-pole renal tumor on the posterior medial aspect. So the standard approach, we are putting the ports and this is liver retraction on the right side. First step, as you all know, is dropping of the right colon. The key here is to identify the difference between the mesenteric fat and the Gerota's fat. As we dissect a little, we'll come to see a slight difference in the color of the two fats. So here you can see the difference between the two fats, and if you go exactly between the plane between the two fats, you will encounter less bleeding. So once you drop the colon, the next step is cauterization of the duodenum. So this is the duodenum, and from here we start dropping the duodenum below. Just keep a 1 2 mm distance above the cirrhosis of the duodenum so that you don't inadvertently injure the duodenum. Now the third step is finding the ureter. This is the right gonadal vein and you will find the ureter just behind it. As you can see, as I am dropping it down, the ureter is visible. Once you identify the ureter, you have to make a plane between the ureter and the psoas muscle and lift the ureter upwards. So we have to keep lifting the ureter upwards until we see the psoas muscle laterally. So that is how I'm doing it. I'm lifting the fascia upwards and the psoas is now visible. See, the psoas is clearly visible now. Now we are putting one assistant port to lift the kidney up so that both of my working hands are free and I can easily dissect the hilum. So we have dissected the hilum and we have found that two renal arteries are there. So we are looping both the renal arteries. Looping of other arteries helps to easily apply the bulldog clamps. Now we are opening the Gerota's fascia to find the renal tumor. So how much you need to open or how much you need to flip the kidney actually depends upon the location of the tumor. If the tumor is lateral, so you don't need to flip the entire kidney, but if it is posterior, then you need to flip the entire kidney. The tumor is not now visible, but we are not able to get all around the tumor. So we need to flip the kidney a little bit more. We have flipped the kidney completely. Tumor is also visible. Now we need to dissect the fat around the tumor circumferentially so that the tumor stands alone and the suturing becomes easier. Dissection of fat is now complete. Now we are marking the tumor boundary with cautery. Tumor marking is complete. We are clamping both the renal arteries. Now we are starting tumor resection. First we cut along the scored margins using cold scissors and then develop a plane as we go inside. Now we have opened the renal capsule, and as we go inside, the tumor margins will be visible. The role of the assistant is very important here. You need a really good assistant. He needs to suck, irrigate, as well as retract at the same time. As you can see now, the tumor boundary is little bit visible. So one hand of the assistant is retracting, the left hand of the surgeon is retracting the other end, and we are developing a plane and cutting along the plane. As you can see how nicely the tumor has been lifted up without enroaching the tumor capsule. Tumor capsule is completely intact and we have reached the lateral border of the kidney. Tumor resection is now completed. Now we are starting the renorrhaphy. I usually close the defect in two layers, first the inner one and then the outer one. One important point here is to keep the sutures that you need for renorrhaphy ready beforehand before you clamp the renal arteries so that you minimize the warm ischemia time. Inner renorrhaphy is done with V-lock 30 suture and outer is done with V-lock 20 suture. Inner renorrhaphy is completed. Now we have made a surgical bolster using Surgisil. We are placing it in the tumor bed before doing the outer renorrhaphy. Use of a bolster is a personal choice. You may or may not use it according to your personal preference. You can use either a 5 mm or a 10 mm hemolock to apply on the suture. Here we are using a 5 mm hemolock. Outer renorrhaphy is now completed and now we are removing the arterial clamps. In the end, we take a few tucking sutures of the gerotas to the lateral pelvic wall.